Okay, well, we get started then. Good morning, members, and I call this meeting to order and declare it open to the public. Before we start, can I remind members of the protocols around electronic devices, and can I also advise any members sitting in the public gallery that mobile devices may only be used through Wi-Fi connection, and they should not at any time make any recordings or photographs are not allowed to be taken. We'll move straight on to the agenda. Item number 1, which is apologies. I have apologies from Pat Sheehan, Ian Milne and Trevor Clark. Are there any other apologies any members know of? No? Okay, thank you. I want to move on then to item number 2, which is Chairperson's Business. And I have several items under Chairperson's Business. First of all, I represented the committee at the College of Occupational Therapists event on Friday last week. They were launching their report around hospitals and length of stays in hospitals and hospital admissions, and we heard some very good work that is being done, very innovative work again by our AHPs who are preventing hospital admissions, and I think we need to praise that. We're here today in this surroundings and we see the good work that's being done here at QUB, and I think there's lots of good work that's being done across the piece when it comes to health. So that was a very good event last Friday. Several members that are here actually in the room today attended on Monday evening, the 14th, Pancreatic Cancer UK event up in 115 at Parliament Buildings. There was a great turnout from the Health Committee. We heard from 2 people that had been affected by pancreatic cancer. One was a relative, someone who had passed away, and another a survivor, which is most unusual when it comes to pancreatic cancer. So a very worthwhile event and a very worthwhile charity. Joanne, did you want to come in?
Yes, Chair, just to commend you, I concur with you in the event and commend you for wearing purple today on World Pancreatic Cancer Day. There's actually 3. There was another lady who didn't speak, but she lost her dad 3 years ago today to pancreatic cancer, and she's doing a massive fundraiser today in Banbridge. So it's wonderful people out there that are doing so much to raise awareness. And, you know, it's still very, as we know, very difficult to diagnose. The symptoms are sometimes far, far too late before people know that they have it. So just to commend Pancreatic Cancer UK, superb event. And I think there's nothing beats that personal story and the personal determination of those that have lost loved ones. And the survivor, Mr. Minnis was a survivor and was very, very powerful in his speech too. So.
Yeah, I think all members that attended, and it wasn't just members of the Health Committee, there were lots of members of the Assembly attended, and I was very impressed by the presentations and by the work being done. So I think it's only right that we give them a shout out here in committee today and support them in what they're doing. Okay, members, I'm going to move on to another item of Chairperson's Business, and that was the KES event yesterday. I opened it again on behalf of the committee. I stayed for one of the presentations and sadly had to leave early, but again that is something that is run through the Northern Ireland Assembly, something that I was also pleased to do. And finally, I will be attending this Friday the College of Speech and Language Therapists, this Friday and Saturday, College of Speech and Language Therapists event. On behalf of the committee again, I have to open their event, their conference on Saturday. And can I just mention again to members, if at all possible, we have the social work event, which I would love to be at, but sadly can't be at, is again, it's tomorrow night. We haven't been able to get a member of the Health Committee to attend that. If any member can, it's in Armagh, and I know it's difficult for a lot of people to maybe get there, but if somebody can do it, can they please get back to us and let us know. So before we go on, I'd like to acknowledge the success of our stakeholder event last week. I'm sure that we all learned a lot, and many of those that invited found it a really positive experience. And I know that we want to build and maintain that sort of positive engagement as we go forward. And at present, the team are writing up the notes that were taken, and we will circulate that in due course. I know I have had several MLAs, as have the committee clerk, from various organisations thanking us and also commending us on the format. And we now have others who are now writing to say they've heard about it and how well it was and how good the format was and want to put their names down for our next stakeholder event. So I want to say thank you to everybody, to all of you for chairing those tables, and also for all of the people that attended. For the information they give us is invaluable when it comes to us making many decisions within the Health Committee. And can also thank the Health Committee staff as well. They put a lot of time and effort into that, and even the briefings beforehand for the different groups that were coming. I think that was invaluable also. So big thank you to everybody else that worked on that as well. Joanne, you want to come
Sure,
in?
just to go back for a second, big shout out tonight. I'm hosting Banbridge Action Cancer at Stormont. Those excellent group, I think there's about 15 of them in total, of volunteers have raised an excess of £50,000 for Action Cancer, and I'm honoured to be hosting them tonight. Paint the town pink in October, as we know. So again, I don't think we can. I know we keep shouting, but we can't shout loudly enough for those excellent volunteers that day in, day out put their shoulder to the wheel and continue to raise awareness and raise much needed funds. So looking forward to that. And again, the event last week was excellent. I was honoured to chair one of the sessions, and I know I have personally been contacted this week by others that have maybe saw it through Twitter and asked how can they be involved with the next one. So we're maybe going to need more tables or a bigger room, whatever. But it gives those smaller charities the opportunity to meet their MLAs and to engage with them. And again, well done to the staff that did an excellent job in preparation. Okay.
Absolutely. Okay, members, that's all I have for you this week. We're very glad to hear on the chairperson's business. I'm going to move on then to item number 3, which is the draft minutes of the meeting of the 10th of November 2016. Can I refer members to pages 6 to 8 of their meeting pack? Are members content with the minutes as drafted? Can I have a yes? Thank you. Item number 4 is matters arising. And can I advise members that the list of outstanding departmental responses to committee correspondence can be found at page 10 of the meeting pack. This list has been forwarded to the department to inquire about progress in preparing these responses. Have members any contact or comment, or are they content to note the list of outstanding responses and return to it again next week? Content, thank you. Okay, item number 5, we'll move on to our briefing from the Centre of Experimental Medicine. Can I advise members that representatives from the Centre of Experimental Medicine at QUB are here to brief the committee of their work? Can I refer members to pages 12 to 14 of their meeting pack? And can I give a very warm welcome to Professor Jose Bengochea, and I hope I've pronounced that properly,
Perfect.
Professor. So can I just ask you if you could brief the committee?
Thank you very much, and it is a great pleasure for me to present what we do in the Center for Experimental Medicine. And if you don't mind, I will go through some slides, and later on, this will be freely available for you, and you can add it to the package of the meeting.
Thank you.
So, the Center for Experimental Medicine, I would say that we are the new kid on the block. So we started 1st of April this year. So we are the latest research center of the School of Medicine of the Faculty of Queen's University. And then just a few simple figures of the center. Our building, which is next door, we are an award-winning building at the national level. So I know that today you want to see this building, but I will be pleased if you have time to host today even a visit, or another time we will be really pleased to host you and give a tour of the center and the facilities that we have. Our kind of current grant income last year, £22 million from competitive basis, mostly 1/3 UK funding bodies, the EU another third, and then the other third major charities. Altogether nowadays we are 46 research groups, altogether 106 PhD students and all the levels of their academic career, and then around now 200 staff. So which is the mission of the Center for Experimental Medicine? If you don't mind, I will read it there, the slide. What we want to do is to accelerate the translation of scientific discovery to clinical application, and definitely to deliver improved outcomes for patients with respiratory diseases, eye disease, and infectious diseases locally, but also globally. Why this is important? Why these diseases and not others? These are just here a few figures, and then I'm happy to share with you which are the statistics for Northern Ireland, but more or less it's rather simple to make the case how important it is for Northern Ireland. In the case of eye diseases, we mostly focus on a diabetes-related complication, which is diabetic retinopathy. Altogether, this disease will affect globally 415 million. In the UK, 4 million, and roughly in Northern Ireland will be around 30,000. The cost of the UK for the NIH in the UK per year is £700 million. Respiratory diseases globally, in the center we focus mostly on asthma, acute lung injury, and cystic fibrosis. And altogether, these diseases, the toll globally is around 15% deaths overall. In the UK, the cost of these diseases per year for the NHS is roughly £10 million. Northern Ireland, I would cost, the last figures is around £1 to £2 million per year of the cost of these diseases. And lastly, AMR, which is antibiotic resistance. I would reflect a bit more on this since this week, promoted by the World Health Organization, it is the World Antibiotic Awareness Day. This is actually, as everybody knows, antibiotics underpin modern medicine. Without antibiotics, nothing that what we do actually will be successful. First, this has been the major change in medicine. In the pre-antibiotic era, we were dying due to infections. After the antibiotics came, actually that was no longer an issue. But everything, every single treatment, every single therapeutics, from the most simple one to the most high-tech one, relies on antibiotics. Just a few examples. Transplants. You know, if you receive a transplant, you will be immunosuppressed because this is what we need to make the transplant successful. Then you will receive a prophylactic therapy with antibiotics. The cancer treatments that my colleagues on CCSCB are really driving force, they do rely on antibiotics because we need these patients, in most of the cases, will be immunosuppressed or they will need to receive immunosuppressive treatments. Therefore, we need to use antibiotics such way that the cancer therapeutics will be successful. And even then, infections, microbes are becoming resistant to the current antibiotics. So just to set a bit the scene where we are. Last year, the UK government commissioned a report, the O'Neill report, on the issue of antibiotic resistance, thinking on the UK, but also globally. So in the final report, the last report that was submitted this February, these are kind of the final figures. In 2050, globally, we will get one death every 3 seconds due to antibiotic resistance. If we translate this to Northern Ireland, to our community, this will be roughly one death every 10 minutes. This may look far away, and that was it is based on a prediction, meaning that if we increase the antibiotic resistance, the isolation of a strain of microbes resistant to antibiotics, 5%, this is the prediction. Nowadays, currently, globally, in the UK and also in Northern Ireland, we're already in the 10% scale. So that means this is already, most likely, it will not work. It will be even higher than this. If we go from the economic part of the business, annually, by 2050, this will mean an annual decrease of 0.5% of the GDP. So you can make easily, and this is based not only on the deaths, but this is based on longer hospital treatments, that a given patient will not be able to work for longer time, disabilities. So this is how it goes for the GDP. So altogether, this is what we focus in the Center for Experimental Medicine, our major focus. So how we do this? Even then, you may think that, there is a bit of diversity in the diseases that you work. So actually, the diseases, these three specifically for us, they are at the center of what we do in our research, and actually we approach all of them by a multidisciplinary approach. And then in the way that we are working in the center, actually across all these diseases, there is a common component, which is the inflammation, which is the immune system, that in most of the cases it is not working properly. So part of the diseases are coming from a malfunction of the immune system. How we approach this? So first, we are coming from the patients. There is always a clinical relevant question in the community that we aim to answer. Secondly, we go to the cell level. And thirdly, we go to the molecular level, so that we understand much better the disease, what's going on, what's wrong with a given group of patients or in the context of disease. As soon as we understand these two levels, and this is what we're doing now in the center, then immediately we start thinking either better diagnosis, better management of the patients, and even running clinical trials, with new treatments, to try to go back to the patient and actually try to solve the medical problem. So this is a bit our research strategy. How we are going to deliver all these plans? In the center, we are going to do this kind of in 2 stages that we are already working in this way. First, we have a 4-year window, so 2019-2020. So this is what we call short-term delivery, and I will show you some of the outcomes that we have already. But then we have an ambitious plan in 10 years' time, 2026, to be really in the front line of a new health concept that I think could dramatically change in the way that we manage our patients in Northern Ireland, and I will go through at the end. So without getting into details, this is what we are currently doing. These are our, so far, successful stories. I will just give you quick flavor of, in all these aspects of what we do. In the context of eye diseases, in 2 clinical trials, Diamonds and Emerald. So here, it is a new laser treatment to treat diabetic retinopathy. If this clinical trial led by us, if this clinical trial is successful, this will cut the cost of diabetic retinopathy patients by 50%. In another one, Emerald, this is try to better manage this same group of patients and try to get a new drug, a repurposed drug that is used in the clinics for other reasons to try to use in these patients. That way that if we need to go to this therapy, the current cost of the therapy is £100 per patient per treatment. This will go to nearly £10. So a significant and major improvement. But then also in a more high-tech, high-profile approach, we're working on cell-based therapies, try to avoid, because these treatments are based on injections in the eye that you need to go nearly every week or every 2 weeks, several times. So the idea would be to avoid that, to use a cell therapy treatment, one go, and then the problem will be solved. In the context of respiratory diseases, we are leading one of the Medical Research Council funded stratified medicine programs in asthma. So the issue of asthma, everybody is well aware. Overall, we can manage rather nicely the patients with glucocorticoid treatments. However, there is an important group of these patients that they do not respond properly to the use of glucocorticoids. So the only way that currently we do is we increase the amount of glucocorticoids because we don't know what to do with them. So the issue of this UK lead program by us from the center is first to really understand this group of patients, whether it is really an homogeneous group of patients or we have different groups, and then the research that has been done in collaboration with big pharmaceutical companies globally in the US and the UK is already indicating that indeed there are at least 3 different groups of patients. One of these will respond to the treatment and the other 2 will not respond to the treatment, meaning that for this group of patients, actually we're wasting resources of the system because they will not work. But for other ones, they will work. In the other one, acute lung injury, this is if, unfortunately, we have a patient in the intensive care unit, this is the typical therapeutic problem that we have that this patient will face. Within 2-3 days, may die due to this acute lung injury. And there is no current treatment, nowhere. So then, what we're trying to address this is first, following this lead, a cell therapy-based approach, so that way that we will limit the damage of that the patient has. So that way, at the very least, we will prevent the patient dying. And then also we're assessing new treatments, but try to repurpose new drugs for this, as I said, this disease without treatment. In the context of immunology, we are working on multiple sclerosis therapeutics, and then we have a really exciting program funded by the Wellcome Trust and the BBSSC, again, on a cell-based therapy that may really change completely multiple sclerosis treatments in Northern Ireland and globally. We might be able to have within, if everything goes as it looks, within 10 years, really a completely brand new treatment for these patients. But also, in a kind of different way, we have discovered mechanistic underlines of obesity and insulin resistance, and then we are working on some ways to try to prevent obesity and insulin resistance, which is a dramatic clinical problem associated to obesity in modern society. And lastly, in the context of antimicrobial resistance, you are well aware of our success therapeutics on cystic fibrosis, that it is already in the market, and this is benefiting already Northern Ireland patients, a way that we have changed really their lives. Actually, we have not cured the disease, but we have dramatically improved their life expectancy at least by 10, 20 years. Then also we are leading an IMI program of new antibiotics, which is the largest grant ever received by Northern Ireland, and Professor Elborn is leading this grant, trying to find new antibiotics to treat cystic fibrosis infections. Also, we have already a successful diagnostics program, because the issue of antibiotic resistance is not only to find new treatments, it is to know when we need to start the treatment. And then, in collaboration with Randox, we have already a successful diagnostics program that it is used in hospitals, not only in Northern Ireland, but in the UK and in the Republic. And then, in my own research, we are working on really new therapeutics against these multi-drug resistant microbes, and then we have some really new exciting data already on the pipeline that hopefully will be really a real breakthrough. But, this is what we're currently doing. And then all of these diseases, all these issues, actually, if you really think that they are really associated also to aging. So now we're getting due to our lifestyle, modern medicine, let's say our successful modern life. Actually, we live longer. So then all these diseases, actually, the toll of these diseases will dramatically increase in our community and globally in the next 10 years, just because we're getting older. So then our frontier approach that I have mentioned for 2026, what we want to do, where we want to be, is instead of being reactive, because this is what we're doing nowadays. We are reactive to the disease, being a bit more proactive in the context of healthy aging. We need to prevent that we're getting sick. We have several focus groups with patients from different diseases, from the local community, and the outcome is, system is working fine with me, but I don't want to get sick. I don't want to get to the hospital. I want that my children and my grandchildren will not suffer any of this. So the concept of healthy aging, this is what we want to promote in our 10-year frontier plan. Briefly, I will not get into detail, which are our bet, which are our strategies, how we will do this. All these are really high-tech, cutting-edge technology approaches that, and some of them were really world leaders. For example, we're going to manipulate our microbiome, the microbes that are living within us, to be not only passengers, but also to help us in the disease. We are focusing a lot on cell reprogramming. It's a way that we can manipulate some of the cells in our tissues when we have regeneration problems or when we have tissue damage, to change this. These host-directed therapeutics against microbes, instead of targeting the microbe, boosting our defenses, and then also this tissue regeneration. The final goal, this healthy aging in 2060, contributing to this healthy aging. And thank you for your time.
Thank you, Jose. That was really very, very interesting. I watched my colleague Trevor Clark to the side of me here when you mentioned injections in eyes. I think he was about to fall off the chair at stage. So it was. I mean, you can see what a difference, that type of laser therapy, as opposed, I assume that's as opposed to the therapy at the moment, and what a difference that can make. I don't know, I haven't too many questions, because I think this is a learning exercise for most of us here today, just to learn and see what you do. I'm encouraged, I am hopeful, actually I'm quite excited. I think that that what you've put out in front of us today just shows us the wonderful work that is being done here in Northern Ireland, and how encouraging that is to look ahead and see what a difference we can make in people's lives. And we know it's being done every day, but we know there's so much more needs to be done. So I thank you for that presentation. Probably just on the first one, just because I know you've already started with I like the sound of it, diamonds and emeralds. I think that sounds rather wonderful. So have the clinical trials started on that yet?
Yeah.
Or yeah?
We are recruiting the first patients, they are already in the trial, if I recall right. For Diamonds, we will start recruiting in next month,
Very
and for
good.
Emerald in 2 months, but the funding is here, paperwork is done, clinical trial is approved, and it is a UK-wide center, both of them, Diamonds and Emerald, 15 hospitals across the, 50 centers across the UK. So final recruitment of patients should finish, if everything goes as it should, the end of next year or in 2 years' time.
Very good. Okay. So not
So
be long before you get the
They
results
have
of that
just
trial?
started the trials.
Yeah. Okay. Okay. Thank you. Can I just remind members that we're on a really tight time frame here today because we have so many people to listen to. So we have about 15 minutes just with Jose here, and then we need to go on to our next one. So I have a few people down. Joanne, do you want to go ahead?
Thank you, Chair. Can I thank you for that? That was just amazing to hear. I was in China a few weeks ago, and I know Queen's research and the work that you're all doing here is just world-renowned. Just a quick question just from the start. You talked about the funding. I think grant income 22 million, EU a third of that. I just would like, maybe it's too early to say, but will you rely heavily, or have you relied heavily to EU funding? I think a third of that. How will you feel then existing research projects will be impacted, and with Brexit, or will that bring opportunities for new links? Have you an opinion on that?
Our current research projects will not be affected in any way by whichever it is the outcome of Brexit. So anything of our short-term, mid-term plans that I have mentioned, let's say they are totally safe, and some of the programs are funded by the EU. So there will not be any impact whatsoever. This has been, we got this feedback from the Commission, the UK government. There is no, we do not need to fear anything. Moving forward, it's difficult to predict how this will affect what we do. Definitely it's a funding that is important for us. Nonetheless, if this funding is not available, we'll seek other one. Definitely is not a scenario that as a scientist we want to live in. So our enterprise is international. We have really links with European partners. We'll still keep going with them, with and without Brexit being out in the EU, so that will not change whatsoever. But definitely as a scientist, it's not an, let's say, nice scenario for us. But at the very least, our research programs for the next 5 years will not be dramatically affected by Brexit.
Okay, given your future links, you would have confidence that those international links will strengthen
Oh,
after
definitely,
Brexit?
yeah.
Okay, finally, just a final wee point, if I may. I was very interested, you talked about AMR and antibiotic resistance, and you've heard the transplant patients and cancer treatments. My son's a transplant patient, and for all his childhood, he was on a low-dose antibiotic to stave off those early tract infections and things, and it's very important with the immunosuppressant as well. How is that advancing, or how close? Because that has been a concern for me, and I know for a lot of transplant patients, the long-term use of antibiotics as well.
For me, on a personal note, when we published last year one of our major pieces of evidence, I immediately got a phone call from a mother from Belfast, actually, kind of with this same situation, but telling me, please, do you have something already? Because my son is with one of these multi-drug infections, and the doctors have said that we cannot treat them. So the issue is that it is a major health problem, and we are not really, from the research perspective, we're trying our best, but definitely we need support. At the end, we need funding, we need resources that currently they are not available to match this dramatic problem. For other diseases, for other contexts, there is enough funding available, and let's say, and things are going, can always be better, but they are going fine. But for the issue of antibiotic resistance, there is a dramatic lack of funding. And then the issue is that everybody's aware, we know, but really we are not doing really anything. And then it's not only about we get an infection or not, it is about all this underpinning modern medicine.
Okay, that's concerning. I was going to call you Professor Bengoa almost, but I think...
we're from the same region, so I know him.
Thank you very much.
Thank you.
Thank you, Joanne. Trevor?
Following on from Joanne tonight, it was AMRs I was understanding in terms of your presentation. In response to Joanne, you said people are aware. I think people are aware, possibly, but not to the degree that you outlined in the slide. I mean, projecting forward to 2050 and actually bringing it into a Northern Ireland context and talking about one person dying every 10 minutes. And I'm not here to disagree with you, but I actually don't believe that people are aware that it is as serious as that. So you did say in response to Joanne about there is funding for all these other aspects, and people are aware of the AMR, but I'm unsure that whether that awareness is actually there as much as you maybe believe, and I'm not trying to be...
No. I fully agree with you.
You scared me when you actually said it, to be honest.
No,
It
but
scares me.
you know, when this data coming from the O'Neill report were released February and actually last year, and then on the scientific community, we were aware of this, and then there was a bit BBC headlines. Hey, this is a big issue, and still, I fully agree with you that perhaps at the public level and some policymakers, they are not aware really. Let's say they are aware of the antimicrobial resistance issue, but what really means is that. So it's not microbes are becoming resistant, but still we have some antibiotics. And it is true, we do have. However, in less than 10 years, we will run out of options. And this is why it's not enough even to be aware, is we need to do something. So it's not enough. This is an important problem, is we need to react, because otherwise we will run out of options. So I fully agree with you. But still we're not there.
Through the chair, I mean, I think it's maybe something that we should... I mean, I think we have a responsibility as well as politicians, because not about scaring people, but maybe to make sure that it is more so on the radar, to try and support yourselves in terms of making sure that funding is redirected, because we all go to our GPs. If you've got the flu, you've got whatever, you get you're expecting the prescribed medication in terms of an antibiotic, and the assumption that this is the golden tablet. But whenever you put the slide up, and in terms of describing the statistics, the first one was scary in terms of a global context, but whenever you bring it into a Northern Ireland context, yes, doesn't look as bad, but to assume that one person dies every 10 minutes is scary. It becomes, I mean, we think of all the terrible diseases that we have in Northern Ireland and what the rates are for those. This actually surpasses those in my mind. So I think, Chairperson, I think this is something that we need to do more in terms of the Assembly, in terms of our research team ourselves, to bring forward and some sort of comparisons to see that, and not trying to diminish what has been said, but are people aware on how serious this is coming down the track?
I think that's also impacted by the amount of new treatments of immunosuppressants for various, like Crohn's disease.
Exactly.
There's lots of diseases out there that are now being prescribed, and that's having a major impact as well. I think you're absolutely right, Trevor. It is frightening. It's really quite scary to think that, as you say, in 10 years' time.
It was not my intention.
Yeah.
It was just to set the reality.
Yeah.
So it was.
That's what we want to hear, the truth.
You know, sometimes in my family, this is kind of, it looks dramatic and scary, but this is the reality. So we cannot hide that. This is the reality.
No, thank you, and thank you at that point, Trevor. And I think we'll pick that up and see what way the committee can go with that in order to assist. Mark.
Okay, thank you, Chair. Thank you very much for that, Jose. It was very interesting, very exciting, and a wee bit scary as well. A couple of the points I was going to touch on have been raised in terms of the reliance on EU funding and how you see that going in the future, and also around the antibiotic resistance. I certainly concur with Trevor that it's something that we haven't been talking about here in Northern Ireland. I do know, across the world, hasn't there been a G8 summit on it? It is a massive issue and massive recognition of it, but you wonder, has it maybe been suppressed or played down deliberately for some reason? In terms of the work you're doing, I think it's obviously fantastic. It's like watching an episode. You wouldn't have been here when we used to have a programme called Tomorrow's World, and it would give you a glimpse into the future. And what we see is very good. However, then also thought of another programme we used to have here called Bullseye, and at the end of that, if a contestant was unsuccessful, they'd be told, here's what you could have won, and see all the things that they missed out on. And sadly, that's something that we're all too familiar with here in the North, where there are treatments available to people living in other jurisdictions, in England, Scotland, Wales, for example, but people here aren't able to access them. So I don't know if there's any work ongoing already between yourselves and the Department of Health here to ensure that whenever you do make the breakthroughs that you are on the cusp of, that those treatments will be available to patients here?
I mean, definitely, and that was one of my recommendations as I said in the briefing, definitely anything that will come out from our research, and it is currently ongoing, all the clinical trials, all the efforts. Our first, let's say, point of contact is our patients, Northern Ireland, the local community. First, we do recruit in Northern Ireland, so it's not most of our clinical trials that we're currently doing, that we have run also in the last 5 years, I would say at least 1/3 of the patients were coming from the local, from the local community. It is true that, let's say, I would say that this part is going really great, and then it is true that sometimes the transition from the research to the health system is not a smooth process. But this is not only a problem for Northern Ireland, it is everywhere. And this is a bit what we would like to make it easier. So with that, everything that we will do here, it will be immediately or as soon as possible transferred at least to our local community. If in England it takes longer time, so be it. But at the very least, Northern Ireland will be the first to benefit for that. And it does require just a bit of, let's say, paperwork and streamlined processes. It's something that can be done definitely. And it will be actually a major step change in transition from research to patients management.
Okay, and obviously some of these huge improvements, and you touched on that, we will see the costs of treatment as well as the times for treatment being reduced, but that will be sort of countered by a huge increase in demand. But obviously, as we do make the transition towards the new system that we've heard a lot about in the recent months, by 2026, the benefits will clearly outweigh the costs. One would imagine. Just one more point would say, and it was on the figures you were given, and I may have picked this up wrong, but it was on respiratory diseases, and the figure came up there at £9.5 million per year, and you added to that for Northern Ireland that would maybe be £2 million per year. But just
altogether,
on a per capita basis, that would suggest to me that then there's an extremely high prevalence of respiratory disease in Northern Ireland, if 20% almost of those costs was comprised by Northern Ireland.
For some of the diseases, for example, for cystic fibrosis, we have Northern Ireland, we have higher prevalence compared to other parts. Asthma also, we are refractory treatment asthma also, we have higher prevalence compared to other parts. And for example, in the ones that we have high prevalence compared to other parts, actually these are the most expensive treatments or longer treatments. So this is why is, let's say, it's not overall in the disease that in Northern Ireland we have bad health. It is, unfortunately, in the complicated ones, our prevalence is slightly higher than everywhere. And then the complicated ones are the ones that require more money to be spent.
But in cystic fibrosis is an example of what I was saying earlier, where Orkambi, for example, can be accessed readily by patients in Great Britain, but not here. I'm actually hoping to establish an all-party group in the Assembly on cystic fibrosis, and I'd be delighted if you could have some input into that. Thank you.
Okay, thank you. I suppose just finally, just to ask you, what's the relationship like between yourself and the Department of Health when it comes to the work that you're doing, or would you like to comment or not comment on it?
I would say pretty good. It can be always much better, but I think is really good. Actually, they do respond. We meet. We're aware. Definitely, I think now we have a great opportunity not to be kind of two separate entities or institutions and come to work together, not to do everything, but few critical issues or few critical diseases or pathways for health, whatever. I think that is what still is not working as smooth, as perfect as it should. But overall, I would say pretty good.
Okay. Okay, well, can I thank you, Professor Venkatjia,
Thank you.
for your witness session today, and we look forward to hearing from you in the future, just on what the progress that you're making. So
Thank
thank
you.
you. Thank you. Okay, members, I'm going to move on to item number 6 on our agenda, which is a brief briefing from the Centre for Public Health. Can I advise members that we have representatives here from the Centre for Public Health at QUB, and they're here to brief the committee on their work. Can I refer members to the relevant papers at pages 16 to 19 of your meeting pack? And can I welcome then to the table Professor Liam Murray, who is Acting Sector Director, Dr Bernadette McGuinness, Consultant Geriatrician and Senior Lecturer in Geriatric Medicine, Dr Dermot O'Reilly, Director of the Northern Ireland Administrative Data Research Centre, Professor Michael Donnelly, Head of the Health Service Research Group Centre for Public Health, and Professor Frank Key, Deputy Director of CPH and Director of the UK CRC Centre of Excellence for Public Health Northern Ireland. There we go, that was a long list to read out. You're very welcome. Have we got someone missing then? Oh, there he comes.
He was doing his hair.
And it looks very well as too. Okay. As you will have been made aware of before the meeting, we're on a tight time scale here today. So I know each of you have something that you want to say. We're going to try and keep you. Is it to 2 minutes each? I'll give you a little wave whenever I let you know, because we want to allow some time for questions as well. So if I can just ask who's going to start, or
Well, I will
Okay,
start,
Liam,
if that's
thank
okay.
you.
And I'd just like to say thank you for coming to Queen's, and thank you for giving us the opportunity to speak about the work that is undertaken within the Centre for Public Health. We've had introductions, so and we'll try to keep to our allotted 2 minutes. I've brought a number of people here because we are a multidisciplinary centre and we each have a different area of research, and I thought it was important to show it all. But I'm just going to give a brief overview of the Centre for Public Health, and then Bernadette, Dermot and Michael will talk about some of the research that we are undertaking. And Frank's going to wrap up the presentation by telling us a few things about public health in general, some principles related to public health and public health research. So we're quite a large centre. We have 135 staff, 35 academics, supported by more than 50 admin or technical staff, and we have about 44 postdoctoral researchers. We have currently 83 PhD students registered with us, so some of those are from overseas. And we run a one-year Masters in Public Health with about 30 students on that course each year, and at the moment 15 of them are from overseas. In the last year, we've had about £22 million of research income from external sources. And the most of that is from outside of Northern Ireland, from granting bodies such as the UK Medical Research Council, the Economic and Social Research Council, Cancer Research UK, Alzheimer's Society, etc. Some of it does come from within Northern Ireland, some of it is from the Health and Social Care Research and Development budget, about £3.5 million over this 3-year period, which is about 15% of our income. We have 3 multidisciplinary research groups, one which does broad public health research from prevention, for example, behavioural approaches to improving physical activity, through to the evaluation of large-scale infrastructure developments, such as the public health implications of those, such as the Connswater project in East Belfast. And then we have a group that focuses on the etiology of disease, an epidemiology group, primarily cancer and renal disease. We host the Northern Ireland Cancer Registry, so this epidemiology group makes use of the data and the capacity of the Cancer Registry. And we have a health services research groups which looks at the organisation and delivery of care, in particular in relation to mental health, to eye disease, to oral disease and cancer. And I suppose our broad research aims are to maximise health and healthy ageing, to prevent and help prevent and manage chronic disease and disability, and to improve the delivery of health and social care in Northern Ireland. So I'm going to pass over to Bernadette now, who will talk about the Nicola study.
Thank you, Liam, and thank you again for inviting us to speak. I'm going to talk about the Northern Ireland cohort of longitudinal ageing. And you all know from the Bengoa and from the Health Minister's report that the proportion of people in Northern Ireland is rising exponentially. And in particular, the number of people who have 2 or more comorbidities is rising. And this has huge implications for the future health of older people in Northern Ireland. And we hope that through Nicola we'll be able to inform healthy ageing and also inform policymakers on how to implement healthy ageing. So the Nicola study has recruited 8,500 men from all areas of Northern Ireland, so all of your constituents are represented in this study. All of the participants are aged over 50, and it's a longitudinal study, so we will repeat measures every 2 to 4 years, and we hope that we'll be able to do that for at least 10 years. So we will have a very comprehensive assessment of these participants' ageing. There are 3 components to the Nicola study. The first component is the computer-assisted personal interview, and an interviewer comes out to the participant's home and they ask them very broad questions on their health behaviours, their overall socioeconomic health, etc. The participants are then asked to complete a self-completion questionnaire, and in that they're asked very detailed questions about their nutrition, about their physical activity, about their mental health, and very importantly for Nicola, the legacy of the Troubles is also covered. The participants are then invited to the clinical research facility in the Belfast City Hospital for a very comprehensive health assessment. And here they have a general measure of health along with cardiovascular, respiratory fitness taken. We look for measures of frailty, we do cognitive tests, and they have a very comprehensive examination of their eye health as well, which is unique to Nicola. So I know time's short, so I just want to show one result that's been of interest to us so far. So this is from the computer-assisted personal interview, and we've looked at prevalence of disability, and we've compared results from Nicola to those in TILDA, which is the Irish longitudinal cohort of ageing. And if you look firstly at this bar chart here, Nicola are the participants in the dark colours, and this is TILDA then in the pattern coloured, and this is male and female. So overwhelmingly you can see that in Nicola the proportion of people who report no disability is actually 20% higher, or lower, sorry, than it is in TILDA. So we have many more disabled people in Nicola than we do in TILDA. And we broke it down into basic activities of daily living, so that's how you wash and dress yourself, for example. And we looked at instrumental activities of daily living also, and that's how you manage your finances or your medication. And again, you can see in Nicola, in both males and females, the proportion of people who have at least one disability in this is actually 3 times higher than it is in TILDA. So there's obviously further work needed to ascertain why this is the case, and we also need to follow these people over time to see what happens, and we also need to look at the impact of welfare reform on these people. So future plans then, the health assessments are ongoing and we aim to finish these by May next year. We will publish our first Wave CAPI summary report by mid-2017, and then we are busy getting Wave 2 CAPI launched for February 2017. And a very important plan in Nicola is to engage with policymakers and to engage with the Northern Ireland Government to help provide healthier, active lives for people moving forward. Indeed, we know the Commissioner for Older People did cite the Nicola study as a very useful tool for looking at changes in policy going forward and how they impact on older people. So we're very keen to keep engaged with that. And we just want to thank the funders, and in particular draw attention to the fact that the Northern Ireland Government has helped fund this study. We have funding up until the end of Wave 2 CAPI, but beyond that funding isn't secured. So we're here today to implore a little bit as well for further funding. Thank you. Oh, Dermot.
Thank you. Okay, I'm here today to say something a little differently, which is that a lot of the answers to the questions the committee and Northern Ireland has in general can be answered without any excess resources or looking for money or infrastructure. They can be answered by better use of what already exists, of making better use of our resources, by which I mean data. We live in a data-rich society, but we actually don't use it sufficiently well. And what I've been doing for the last few years is trying to put in place some of the infrastructure which will allow us to make better use of routine administrative data and to allow safe linkage of these various data sets. When I say safe, I mean at world standard levels, and when I mean safely, I mean that such that no individual, patients, clients can be identified, and that the Information Commissioner sits on our steering group, for example. So it's all done perfectly well, but we can learn very useful lessons from that. The Administrative Data Research Centre is one such infrastructure you may have heard about, and if you haven't, you will be hearing a lot more of it. The Honest Broker Service in the BSO is another one way of linking these data sets together. So we can learn an awful lot more about our society, about our health services, the effectiveness or otherwise of that, and the factors that lead towards disease if we make better use of our data. That's the underlying theme. These are some examples of work we have done, work we are about to do, and some potential answers or questions that could be answered by use of data. So we have spent some time looking at the factors that are related to admission to care homes. We are probably one of the best people in the UK and the world to tell you about the health of informal carers, and we've just linked prescriptions and admissions data for older people, and we can tell you very detailed information about the over-medication of older people in care homes. We're about to start a study looking at the health of migrants in Northern Ireland, and we are getting more involved in mental health research and in self-harm as well. We are starting to try and look at the long-term consequences of children on the at-risk register and what happens to looked after children, especially after they leave care. But to do that effectively, I think we need help from this committee. We can linked information has also been used to look at the effects of airport noise on health. Belfast George Best Airport on health. It could be used to look at the relationship between health and education, and education and health. And if you wanted to look at the effects of the wider effects of, say, welfare reform on the health of people or other impacts, come and talk to us. We have the tools in place to allow you to do all of that. And of course, if you want to look at the effectiveness of change of your services or who's using them and the variations and inequalities, better use of the data that already exist can provide a lot of the answers for the questions you'll have now and the ones you'll want in the future. So, thank you.
Thanks, John. So I'm going to say a little bit about the newly formed Health Services Research Group in the Centre for Public Health. Our health services research studies tend to focus on services for people with chronic conditions and on services for older people. We've been saying for some time now that our services and our care systems are too acute-centric and that we needed to have this shift in the balance of care. And arguably this idea about balance of care and getting a better balance of care is the underlying theme of the Bengoa report. It's certainly a theme that connects the different collection of studies that we have. So, firstly, there's a need to have good, rigorous needs assessment studies. And some of our work, for example, on needs assessment of this new and growing population of cancer survivors has facilitated the long-term care planning of that population. And then secondly, there's a need to assemble best available evidence and also to translate that evidence for decision makers, for policy makers and for practitioners. An example of this, the most recent example we have is one of our Cochrane reviews, which synthesized best available evidence for the effectiveness of reablement services for older people. And then, in order to be patient-centred, our health services and our health services research studies need to measure or attempt to measure and incorporate measures of the patient perspective and the views of service users. And so some of our studies have developed specific patient reports about health-related quality of life and health status and functioning. And these have been used then to evaluate services, for example, the cancer services and services for frail older people. And then much of our research time in the Health Service Research Group is spent on looking at studies of specific interventions and specific services. And this also includes work designing new interventions, and some of our researchers are working on developing a care program to counter cognitive impairment due to cancer treatment and chemotherapy. An example of our studies of service organisation and delivery is an evaluation of community-based rehabilitation, where we demonstrated that it is safe and effective to shift that balance of care from hospital into the community and indeed into the home setting, to do that safely and effectively, and also that patients and families prefer it. They prefer it to hospital-based rehabilitation. Now, in addition to answering these questions about the effectiveness of services and patients' needs, there's also the important question about costs and value for money. And an example of that is the ophthalmology services we have. It's the largest outpatient activity in our health service. We have over 100,000 appointments for ophthalmology services, outpatient appointments per year. And similar to other specialties and other services, due to our ageing population and successful treatments, demand is increasing. So there's a real pressure on how to find new ways in which to manage that demand. So in that particular instance, our ophthalmology health services researchers and our health economists, health services researchers are working together to develop new methods, to test those methods and to test the cost effectiveness of them. And then finally, our researchers are investigating methods or ways in which we can assess the quality of services, beginning in this instance with the development of a set of quality indicators for palliative care services. So we think there's pretty good correspondence between... Okay.
Michael, you've gone well.
Over to you, Frank.
Frank, give about 10 seconds.
Okay.
You don't know this guy.
No,
Okay, this report on the left is produced this year by the Academy of Medical Sciences, and what I want to say about them is that they're not public health people. They are the overarching group of scientific experts that are at the top of the pinnacle, if you will. But they produced a report this year on what do we need to do in terms of improving the public health. And we don't have an NHS, a health service. We have a disease service. But this group of experts were saying, where do we need to spend our money, both in terms of the service and in terms of research, to improve the health of the public over the next 25 years? And they talked about more work in the social determinants of health, early years interventions. I was the public health principal and co-investigator on the Roots of Empathy trial in our primary schools to improve pro-social behaviours in primary school kids, here led by Paul Connolly. More work on social relationships and well-being. We have an MRC grant looking at how does Twitter, how can it be used for public health messaging. And on that note, the Department of Finance's Behavioural Insight team approached us a couple of months ago about doing a nudge intervention for antimicrobial resistance awareness raising. And since we had done some work on using social media, that's why they approached us. Digital health and mobile health, big topic in all the research councils, and we're involved in physical activity apps and using mobile health to incentivise physical activity behaviours in some of our trials. Health promoting schools and workplaces, we're working in that space as well. Greater focus on health systems and research delivery, Michael has said about that. And the other thing is cohort studies to support a broad range of broad ageing research agenda. Actually, cohort studies like Nicola are engines of discovery, every bit as important as genome science, and that's the point that the Academy was making. So, if this would work, sorry. So those things really do reflect and tie in with what both the Minister and Bengoa was saying. So where do we need to work? You can either pull people out of the river, which is mostly what the health service do, or like Desmond Tutu says, you can stop people falling into the river. Now, we would claim that we work at the broader social determinants, on the broader social determinants agenda. Of course, we do molecular search as well. Molecules are important, but we want to build fences at the top of the cliff, not at the bottom of the cliff. And on the cystic fibrosis issue, a couple of years ago, I was an external examiner for Dame Margaret Whitehead's PhD student. She produced this diagram a few years ago in one of her textbooks. She's from Liverpool. So her PhD student was an MRC fellow, and he's now an MRC senior scientist, focusing on the outcomes of cystic fibrosis patients. And he looked at the outcome in poor kids with cystic fibrosis compared to rich kids. And the magnitude of the difference in the outcomes far exceeded the magnitude of the difference between the types of treatment they had. So poverty was a real determinant of the outcomes of cystic fibrosis, and much more so than the particular mutation they carried. And that was one of the messages in his thesis. So you can either choose to look for your keys underneath the lamppost where the public attention is, but you should really look broader. Now, this is a modelling study. Sorry for the font being small, but we were looking at the explanation for the fall in cardiovascular death rates in Northern Ireland and in the south indeed. And the yellow, I'm colourblind, I'm assuming it's yellow, the top part shows that the greater part of the fall is down to the changes in the risk factors. The purple, I hope it's purple, is actually that part of the fall that's due to the treatments like balloon treatments, angioplasties. So actually the greater part of the fall in mortality is down to shifting the dial on the risk factors. Thanks, Mike. So I'm divine intervention. So the same point has been made actually about cancer. Paper in last week's BMJ, which was saying that of the 48 recent FDA approvals for new cancer drugs, life expectancy moved about two months on average. So we have to tackle cancer. I'm not going to pitch one thing against the other. We have to do both. That's the point. And whenever you work on social determinants upstream, there's the potential for huge benefits. It tends to be more effective when you work upstream. And the example is diabetes. You've heard any number of reports on diabetes and how it's going to bankrupt not just our health service, but the health service in the UK and any developed nation. It's a disease, type 2 diabetes, that can be prevented with lifestyle interventions very cost effectively. The last part of this slide is whenever the National Institute for Health and Clinical Excellence reviewed the cost effectiveness of all the public health programmes that it had produced guidelines on in the last 5 years, they're extremely cheap. So, as I say, I'm not pitching one thing against the other. It's the fact, where do you have the biggest bang for your buck? You do have it with public health interventions, which, like the Public Health Agency's budget, is probably less than 2% of the total NHS budget in Northern Ireland, and they do a fine job. So let's spend much more time on what's important, and that might be the upstream things. Let's not build the fence at the top of the cliff. Thank you.
Okay, thank you. Thank you, everybody. Members, we've got about sort of 10 minutes, thanks to Michael and his overly long presentation. Can I thank you? I think as a health committee, your resources are going to be invaluable to us over throughout this mandate on some of the reviews that we want to carry out. It was really interesting to see just the broad spectrum that all of you cover. So thank you for that. Especially, I want to just hone in on Dermot a little bit there, because I know, I've seen on your slide it was the informal carers and mental health and self-harm. I mean, that's something I think that as a committee that we have already committed to looking at mental health, and we're looking at the role of informal carers, and we know that most people don't actually see themselves as carers. So I think that data and that information is going to really help us with some of the work that we're going to do, along with lots of other things that are in that. So you're going to be hearing from us.
Can I ask you to help me to help you to help Northern Ireland?
Okay. You're not going to ask for money, are you?
No, not at all. No, actually, not at all. But that's unusual. Actually, if we're smart, actually we can get other people to help us to pay for the research to answer our questions. So, for example, I'll give you two examples. One, I was in London, an interview with the NSPCC, and their funding call for looking after what happens to people on the at-risk register. long-term mental health consequences of that. And we're linking data. We've got some of the best data in the UK sitting here. And whether we get the money or not depends on whether we can convince them that we can actually utilise the data here. It's sitting here, doesn't mean to say we get access to it. Things are very slow at getting access to data here and making those data work for us. I'll give you another example. So that would be £250,000 to answer our questions about what happens to look after children and people on the at-risk register. And so I'm not looking for resources. The resources are already out there. But what you can do is help get those data, those information flows and those data flows working better for us. Give you another example. That came out yesterday, the self-harm register. So, and I've been trying to make these data work harder for us and give us more answers for the last 4 years, and it hasn't worked. So what's the relationship between self-harm and suicide? We don't know, because we have never linked those data. I can do that. And I can make that happen and get those answers relatively quickly. But I need your help to help overcome some of the resistance, some of that slowness and conservativeness about how we look after our data. We can handle these data superbly safely, but actually get the answers again without asking for money.
And so many times, Dermot, we hear whenever we put in questions or whenever we ask questions on numerous issues that we don't have the data. And I think you have lots of data captured.
We're awash with data.
Yeah. Which helps inform, even specific areas, or, as to what's more prevalent in specific areas as well, which is something that we're very interested in also. So it's really refreshing to hear that you have lots and lots of data out there that nobody seems to know about. And I think that we need to, nobody that gives us answers seems to know about or want to tell us. So that's good to know.
Yeah, come and talk to us.
Yeah, we will be. I think you might fine. You'll be asking us to go away after a time. No. You will. Other wee bit I just wanted to ask quickly on, because I know that I'm conscious of time here, and we have a couple of members down to ask questions. Was to do with the cancer registry.
Yes.
And you know that we're looking at backing a cancer strategy. We're very much behind that as well. Well, many members of us are behind that. What do you see that making a difference to the work that within that?
Well, I mean, I think I'd like to make a point that the Cancer Registry is one of the few registries that is actually based within the university in the UK or worldwide. Yeah. So, and I think that is a very beneficial arrangement, because it means that the rigour of research is applied to the approaches that the Cancer Registry uses to generate its data, evaluate its data, utilise its data to improve services. So I think it's important that we continue to retain that relationship, and also from us within the Centre for Public Health, utilising the Cancer Registry and the opportunities of the Cancer Registry to do our research to give a better understanding of what causes cancer. That benefits from that the university relationship with the Cancer Registry and embedding the Cancer Registry within our centre. As regards the cancer strategy, we do need a clear cancer strategy for the Northern Ireland. Cancer Research UK has been making this case for some time. I believe Margaret Carr is in the audience and has maybe presented to you and talked to you about this earlier in the week. And part of that informing the cancer strategy is the data that we generate within the Cancer Registry, and utilising that the best possible to ensure that services are delivered where they're needed, etc., and evaluated. So I'm fully supportive of the idea of having a properly well-developed cancer strategy for Northern Ireland, yes.
Okay, thank you, Liam. I have Jerry and then Catherine.
Thanks, Liam. Thanks, everybody. It's a great presentation, and indeed you do great work, aware of it. Just two questions. I mean, you didn't sort of mention it, probably due to the time constraints, but we've had a sort of discussion about health inequalities, and how I think in our papers later on there's a gap between women who come from deprived areas or effectively dying 11 years earlier than women who are from more well-off areas. I think the gap generally is 14 years. So I know you're research-based, but any comments on that would be welcome. And just to touch upon the welfare reform, because it was mentioned twice, maybe tease that out a bit. I think the PCS trade union, in terms of welfare reform in Britain, noticed a spike in suicides when welfare reform was implemented, and people may have seen Daniel Blake, the film captured that. So in terms of welfare reform, what is your assessment or likely outcome to be? I mean, obviously people will be further pushed into poverty, but do you see a rise in suicides, mental health problems and general health problems? If you could comment on those 2 points.
On the specific issue of welfare and welfare reform, Dermot and I actually sit on a committee in the Department of Communities, the Benefits Uptake Advisory Committee, and we know a lot of the good work that their NISRA statisticians are doing to try to understand that issue. From our perspective in the Nicola study, we not only have the self-reported disability, we also have self-reported claims and objective measures of disability. So over time, as welfare reform kicks in, we will be following this same group of 8,500 people to see what has happened and what has happened to their mental welfare and their physical disablement, if their entitlement changes, for example. So Nicola is ideally suited to address some of those issues. Dermot, you were going to add?
Yeah, if we take those in order. The life expectancy, I was probably one of the first people in Northern Ireland to calculate those figures 20 odd years ago, and also then not there's still the gap in life expectancy, but the bigger gap in healthy life expectancy as well. We can study those and provide figures for those on an individual level, not just area based, which it tends to be because of the data. We can also look at the changes in social mobility over time. We have one project going on there and looking at the differential changes in social mobility across the province. We've also looking at educational attainment, which is oftentimes you're looking at social mobility is one of the engines of social mobility, and we're looking at the factors that are related to educational attainment or not by family, individual, area, and school level factors as well. So there's lots and lots and lots of potential. Taking in all of those wider aspects that influence on health inequalities, they're all there to be studied, and we have studied them. Though I suspect the answer is fiscal change. But that's anyway. The other thing is, you asked about benefits. So the infrastructure is there to look at the changes. The Margaret Whitehead, which Frank mentioned, and her studies have done area-based studies suggesting increase in suicide rates. But we can do that on an individual basis. And we can also not look at the people who have got their benefits changed, but the wider influence on their families as well. And though not just health, but if, say, for example, divorce rates increased or people moved houses, we can answer all of those questions in Northern Ireland, for Northern Ireland people.
Could I just add one thing to Dermot's answer on inequalities? I mean, generally inequalities are better addressed whenever you intervene at the whole population level. If you rely on individual agency, on people changing their own behaviour, it's a struggle for people living in poverty. But if you act at the whole population level with like minimum unit pricing for alcohol or something like that, that's where you get a bigger impact.
And just through the chair, I mean, I suppose it's a political issue as well, obviously, but just do you, Dermot, as well, your research on migrant health, do you have I don't want to pressure for a deadline, but do you have any time?
Starting time would be It's again difficulties getting access to the data. We are that project will be starting either in December or January, so it's very imminent, and it's been in the pipeline for the last year and a half at least. So it just takes the time it takes to do it. The answers will be coming in as quickly as we can get them. All of our answers, all of our findings will be on the web. We'll offer to do test seminars and everything else. We like to interact with policymakers. There's an event happening in Stormont on the 7th of January, so or February, come and hear what we're doing as well. So happy to keep you posted up to date. Anything we're finding on that.
Thanks.
Okay, thank you, Catherine.
Thank you, and thank you all for your different presentations. They were very interesting. I have two questions and then just a wee comment on Frank. And Frank, you mentioned the link between education and health, and I think that's crucially important. I also really liked your analogy about looking under the light. I think that's what our opposition parties are doing in relation to Bengoa and the Minister's report, looking where the light is instead of at the report. But my first question is really for Bernadette. Bernadette, in relation to the Nicola project, it sounds brilliant for looking at improved knowledge around treating an ageing population, and we know that that's one of the biggest pressures on our health system at the minute. Is there any focus towards sort of like improved early preventative measures, so early intervention for younger people who are presenting with problems, particularly, you know, children?
Well, it's a cohort study on ageing, so the minimum age to participate in the study is 50, so we don't have younger people in the study. We do look at families and overall circumstances in families, so there may be some information gleaned that way. And it's not an intervention study either, it's a longitudinal observational study, so we won't be intervening in any specific way really either. So the answer to that question is probably mostly not.
We do work closely with Professor Paul Connolly's unit in the School of Education, and one of the things which we funded with Paul was converting the existing Northern Ireland Statistics and Research Agency survey of school children, which is a cross-sectional survey. We put a little bit of extra money in that to make it a longitudinal study. So we're actually following school kids that were in the NISRA YBAS survey, Young People's Behaviour and Attitude Survey. We're actually following them over time with Paul Connolly. And we do a lot of schools-based trials with Paul, intervening in school kids. The Roots of Empathy trial is in primary school kids around about 6 or 7 years old, about trying to improve pro-social behaviours, which is linked very strongly to health behaviours in later life. And we've done some smoking prevention trials in secondary school kids as well, along with the Public Health Agency and Cancer Focus NI.
Thank you. I think it's just linking into Jerry's point about life expectancy in the deprived areas and how we're capturing that data. My final question is just really geared towards Dermot. There's a lot of data out there, and sometimes it's frustrating. I don't know if other members find it, but a lot of the data we work with is UK-wide, and sometimes there's not the breakdown for the North put to us, so it makes it a wee bit more difficult when we're dealing with issues. So it's really just to ask, do you think the problem around data is how we're capturing it or getting it, or is it more about compatibility across the whole sector?
Good question and a complicated one. I'm conscious time short. We have a lot of data relating to our citizens in Northern Ireland here that we could be making better use of. Sometimes it's appropriate if we don't have the data, we draw by analogy from Scotland, Wales, England, wherever, or further afield. That's quite appropriate. But I still insist that we're awash with data here. The problem is not actually sometimes having the data, it's actually making it flow freer, easing up on those stops, that conservatism about linking those data sets. And if we did that, actually, we would find we probably have answered a lot of the questions.
Do you think, just quickly, do you think it's people that are precious about their data?
Absolutely. It's always people. It's not. There are precious little legal impediments to sharing data. There are no technical obstacles anymore for sharing data. It's actually all about people's custom and practice, which tends to be very conservative.
Okay, thank you, Catherine. Okay, I now have Mark and Trevor also to ask questions.
Okay, thank you for that again. I know it was very much just a quick snapshot of what you guys are doing here, but a fascinating one it was, and I'd certainly be interested in learning more. And there's a lot more we could delve into. Just I enjoyed a few of your analogies, Frank. I'm not quite sure.
I was actually getting a bit worried, Frank, because I think we're going to hear a few of those from Mark in the future.
I'm not quite sure. I'm not quite sure I got Catherine's right enough when speaking from my own party's perspective. Certainly, what we've been trying to do is shed light where there is darkness in terms of the Bengoa report and what the Minister has come out with, and there's people who thrive on data. I'm sure you concur that there are quite a lot of grey areas, to say the least. My question is actually to Bernadette. It's around the differences, I suppose, highlighted in the comparison between Nicola and Tilda, and that huge disparity in terms of disability here and in the south. Imagine then there's a further breakdown of the type of disability we're talking about, or would you be able to say, just off the top of your head, how much of that is related to mental illness, for example?
Well, this was disability, looking at, we divided it into basic and instrumental activities of daily living. So we looked at, as I said, your ability to wash and dress. So it was more physical disability. And then the instrumental activities of daily living can relate to both mental and physical disability. So if you're developing dementia, for example, you will have a difficulty in managing your medications or in managing your finances. So there's a little bit of both in there. We haven't yet had time to deconstruct it totally. But we do know, and it relates to what Jerry was saying, that the disability rates also correlate with education in Northern Ireland. So if you were only primary school educated, your disability rate was much higher than if you had a tertiary school education in Nicola. So it correlates also with that disparity in life expectancy as well. But there will be further work ongoing in that, and we'll also, as we said as well, in the health assessment, we'll have an objective measure of disability as well as a self-reported rate, because it may well be that Northern Irish people report disability more than they do in the South. Perhaps they're more stoic in the South, who knows. But because we'll have these objective measures as well through the health assessment, then we'll be able to determine better what exactly is going on.
And while we have Nicola and we have Tilda, and those comparisons are extremely useful, have they any other cousins
Yeah, we
over
do.
the water?
Plenty of cousins. We have Elsa. So you seem to need a girlish type name to be a longitudinal study. So Elsa is the English longitudinal study of ageing, and it's actually, they're just launching Wave 7, so they're much more advanced than us. And when Nicola was being set up, it was set up in such a way that it would run in parallel with Elsa and Tilda, so that findings would be comparable against the studies. And interestingly, Scotland have just launched their first longitudinal study of ageing, and they're quite unique in that they've called it Haggis. So, yeah. So they've been brave and they've taken away the female name. So Haggis in Scotland, and that's so. All these studies are designed to be complementary to each other.
Okay, thank you.
Thank you. Trevor?
Mark's touched on some of the area. It's in the same area. I mean, I don't want to ask for the slide up again, because it's probably difficult to get the slide back. But on the first column, what was the first question in the column? Because I'm trying to recall what.
It was no disability. So that's why it looks different to the rest of it. So
Yeah, that's why. I mean, because on that, from recalling that, actually Tilda showed higher. Yeah, well, that was
higher
right
rates of no
enough.
disability.
No disability. Yeah, that's why. Because I was that busy reading the next ones, I couldn't recall that.
Yeah.
The other thing, I suppose, and I'm not trying to be critical, but I am being critical at the same time, because if we look at. What's that? No, I'm not talking about the age profile of the members. Okay? Because I wouldn't want it, but I'm not quite 50, but some others might be. All right? Yeah. Well, I'm still in the 40s.
Or members.
The difficulty with, I think, sometimes asking people the question, and I suppose it's a bit like the age, people try to hide what age they are.
Yeah.
But I think sometimes people, whenever they actually respond to some of this stuff, and I'm not saying in terms of this directly, but I don't think people are always honest about. I think if we look at welfare, I think welfare is a good example. People will exaggerate conditions to put themselves in a different position in terms of how they will fare out in the benefit system. And I think we all experience that even in terms of our offices, where we would assist people with DLA or PIPs, and they're hardly able to walk in, but you see them the next day and they're running up the street. You know, so I think sometimes people, if they're feeding into data, are not always honest. Now, I sometimes concern myself with that.
Well, yes, that's a very.
There's a technical answer, which is that Elsa and Nicola are doing exactly the same thing to address your concern. Within the self-completion questionnaire, there's a thing called a vignette, which is, in the questionnaire, you describe a series of 8 people who have a disability. And you ask the respondent to rate how disabled you think that person is.
Right.
Now, whenever you've done that, and you've rated your own, you've got a kind of an external benchmark. And we have adopted exactly the same vignettes as England have done in the ELSA study. So you raise a very important issue, but there is a way to try to partially overcome that, and we're actually doing that analysis now.
And that answers that for me, because, I mean, human nature, I mean, so you filtered that in a sense.
One quick point. If you compared what older people say about their health to younger people, in terms of their self-reported health, you wouldn't give any money to older people because they're getting by okay, thanks.
Yeah.
Right. So, however, it's somebody else said that self-reported health is both more and less than objective measures in health. And the third thing is that actually, in terms of prediction of mortality, self-reported health trumps your GP's assessment, even with full biomedical screening, in terms of your mortality risk. So it it's self-reported, it's subjective, but it trumps what your GP knows about you.
Okay, look, thank you. That has been extremely interesting. Can I also ask, and this is of all witnesses today, can we get a copy of slides? I think we'll find that useful as well, and who we need to get back to, or whatever we're doing at any particular time within Health Committee. So thank you, really interesting. No, I'm not going to ask anybody to declare their age. I really don't want to declare mine either. I'm not ready to do the over 50 assessment yet, I just know that much. Not too far away though. Okay, thank you. And can I then refer members now to pages 21 to 26 of their meeting pack, and advise members that we have representatives from the Centre for Cancer Research and Cell Biology are here today to brief us. And can I welcome Professor David Waugh and Professor Mark Lother, while Mark's handing out brochures. You maybe come and take a seat. These are both very welcome. I'm saying very welcome to everybody that's come here today, and actually we're in your place, so we are. You're not in ours. So if I can hand over to yourselves. I know that we're on. The last presentation ran over slightly, but we'll just see how we get on. Then, as we do our walkabout, we might want to then further ask questions during that, if that would suit as well. So I can hand over to you.
Well, first of all, thank you, and indeed, welcome to our home. And it's great to have you here, and I'll echo the sentiments of all of my colleagues who've gone before in ensuring that this is really an important undertaking for us. This is the Centre for Cancer Research and Cell Biology, which really cuts across both preclinical discovery, precision medicine, and actual clinical implementation using the infrastructure that we have created across the Belfast City Hospital campus. And I'll try and exemplify how that really is dedicated to changing patient outcomes. So we have and call this a comprehensive cancer research programme. And in essence, everything that we do in this centre is geared around the patient. If the science is not relevant to changing patient outcomes, I will not stand over it in this centre. So all of the academics, all of the research team, and it's a 300-strong research team, are really focused on this key mission, which is to integrate preclinical, scientific discovery, in other words, and clinical research. And it's really to accelerate the application of those research discovery findings into the clinical care pathways to benefit patients, both in terms of outcomes and the quality of life that they experience while they're facing and fighting cancer. So that is our very clear mission statement. How are we driving that? Well, the way in which you actually start to accelerate discovery is to build an innovation pipeline. And this is how we have constructed this, and this is really important in terms of changing the Northern Ireland ecosystem in health. This is how you build academic research using disease-focused groups, and I'll explain that in a little bit later, using the academic infrastructure to drive scientific discovery. We link that to the indigenous and increasingly external biotech, pharmaceutical, diagnostic research community, which is in the private sector, and this is really important, in order to develop the products and the technologies in a format that then can go into the clinical arena and drive innovative clinical trials. And it's really about interacting academia and industrial partnerships with healthcare that we are developing the knowledge and the products and the assets and how we can get that into patients to change their lives. And that's really how we are geared up in this centre. The impacts that this centre is having is sort of laid out before you. First of all, it's about driving an increased resource for cancer research around patient care in Northern Ireland. We have now a very innovative clinical trials portfolio. Wasn't here 10 years ago. It is now. And clinical trials are the way you improve patient outcomes. It's about how you bring in a diagnostics programme. We have the best in the UK, if not Europe, sitting literally just across the corridor. It's about academic leadership in molecular diagnostics. If you take a car to the garage, there's no point changing a spare wheel if the engine's bust. You need to know what you're facing. You need to understand the diagnostics and real detailed diagnostics of the tumour that the patient experiences in order to align the right therapy. And we have one of the best facilities in Europe to do that. And it's about how we're changing radiotherapy programmes. And it's all about academic leadership. And one of the things that is highlighted in Mark's report is how our academic programme is now bringing forward new programmes in stereotactic ablative radiotherapy. That would not be happening in Belfast if you did not have the academic leadership from the university on the clinical side to drive that implementation. It's about how you catalyse dynamic change in the ecosystem. So that's about recruiting world-class leaders. Manuel Salto-Tellez, David Gonzalez, Next Door Diagnostics, Joe Sullivan, Richard Wilson, and all of the individuals that we're recruiting on the medical oncology front. And how you build those world-class leaders on the clinical and the scientific front. We don't have time to get into that. It's how you train the next generation. You have to have the right environment and leadership and opportunities to train the next generation that are going to take on the legacy of what Mark and myself and all of my senior colleagues are driving and bring that forward into realisation in the years to come. It's about how you're building a research infrastructure that enables this innovation to happen. It's how you build SME activity, how you start to put research discovery out into the private sector, acquire different funding levels to build that innovation, build economies, and then get those products into care. And that's also driving inward commercial investment. So all of this is happening at a very significant pace now over the last couple of years within the cancer programme. It's about how you're accelerating research engagement then with the trust and local parties and industry to really help build and bolster that connectivity. And as a result of this, I am confident that what we are doing in this centre and across this ecosystem on this campus is changing patient lives, and it is having real impacts on outcomes. And Mark's report taps into a lot of that. How do we bring this innovation to patients? Well, it's about how you integrate all of these activities. There's no point having things disconnected. And we've built a pathway to patient impact, which integrates our genomics research, our pathology research, the cancer registry data that you've heard about, the biobank, to enable us really to drive biomarker discovery or new diagnostic development in Belfast. It's about how you use that then to link in and make sure that you've got the right laboratory research models underpinning how you're understanding the right driving biology of the disease and then how you line up the right therapeutic. And ultimately, as a result of having biomarker discovery and a real understanding of what the biology of the cancer is that the patient experiences, you're lining up biomarker-guided and biologically informed clinical trials. This is precision medicine. This is the best opportunity that we have to bring curative intent to patients. Not only is it about how the academic infrastructure and the healthcare infrastructure aligns to it, it's how you map on commercial activity. As I said, it's really important to drive the commercial piece because that's how you build the new products. And I'm really delighted to say that as a result of the centre's activities over the last number of years, we've also created a number of spin-out companies that are now bringing high-value jobs to Northern Ireland people. Almac Diagnostics, Almac Discovery, Randox was initially a Queen's entity. PathXL has just been acquired by Philips. Analytics Engines is a Queen spin-out company around data management. And CV6 is a great poster child that this model that we've put together in the cancer programme is actually attractive to external companies and individuals. We recruited this company out of the University of Southern California in Los Angeles. And they left a fantastic ecosystem to come to Belfast simply because of this vision. And there are many, many more companies that I'm talking to across the world that are interested in following their model, following their journey, and actually seeking the benefits of working in Belfast. We'll come to that in just a bit. So this is an exciting time on the campus for cancer. We have the preclinical discovery building that you're currently sitting in. We have just acquired the Precision Medicine building, which is just up the innovation corridor, which is housing a lot of our academic industrial partnerships. And you can see your First Minister teaching me a chemistry lesson here in the Drug Discovery Lab led by Almac Discovery and Tim Harrison, our Biomarkers and Stratified Medicine Group. Here's Alistair Hamilton from Invest Northern Ireland, myself, and Bob Ladner, the founder of CV6 Therapeutics, celebrating their launch of their facility in Belfast. The Biobank and Manuel Salto-Tellez and Jackie James, and the innovative work that's going on around the molecular pathology programme. And essentially, discovery here goes into this building in some context, and then the products of this come into the cancer centre and are taken forward by these tremendously talented young clinical academics to change outcomes for patients. And it's importantly about how we build onto this framework. It's about how the university will continue to invest. It's about how we build further investment into building the biotech cluster around us, and it's about how we drive a biomedical research centre, because this is the key piece. We cannot have the last part of that innovation pipeline falling down on the issue of capacity. We need increased capacity in our healthcare sector for research and driving this innovation into patient care. We are focused on disease entities. It's about addressing science that addresses the key clinical questions, the barriers that patients face, the barriers that clinicians face. And ultimately, as a result of that, we get the translational outputs. We're driving precision medicine in a very focused way. We have gastrointestinal disease as one of our key focuses. And you mentioned earlier on pancreatic cancer, an area that we are continuing to invest in because we've recruited a clinical academic to drive that innovation in the patient care pathway. Also, prostate cancer's Movember Centre of Excellence is here, which I co-lead with colleagues in Manchester. But the key thing is that our centre is leading on a number of key areas. We're leading the accelerator in pathology. We're leading an ESCORT national programme in colorectal cancer, the Fastman Centre of Excellence for prostate. Mercuric is a trial that is driving Belfast science across 13 major cancer institutes, 8 European countries, but it's Belfast science that's underpinning the context of that trial. And it's also about how we've been involved in the precision medicine catapult, but clearly our excellence has been recognised in that. Is this pipeline working? Yes. Assets that have been developed by our sector, our pipeline, have now been commercialised to the significant revenue benefit of Northern Ireland companies and patients. Are therapeutics working? Yes. Well, I didn't copy that slide. We've also commercialised assets in the therapeutic space. So diagnostics and therapeutics have gone all the way through from a university discovery into a clinical asset that has been shown to have clinical value in patients and commercial value. The challenges, I would say, is that we have to focus now on demolishing further barriers to innovation. We've shown it can be done in Belfast. There is an appetite for it. But the challenges to healthcare, government, academia, industry. One, precision medicine requires a change in practice. We must focus on that. We must embrace research and service delivery. Service will be improved. Patient outcomes will be improved by driving research. We must have bold commissioning. There is no point to have the assets developed in Northern Ireland and available to US patients, as they currently are, and they're not available to Northern Ireland patients. Unacceptable. You need to drive adoption, and that's one of the pieces that this centre is focused on doing. What we need, new infrastructure. The biomedical research facility is absolutely essential. It's not an if, it has to happen. I implore you to get behind and make sure that we can try and seize that opportunity. The infrastructure for SMEs, really essential. We have a lot of companies who want to come and drive foreign direct investment in Northern Ireland. If we do not have the facilities for them, they cannot come. We're at capacity. We need to do that. And I'm working with the Science Park and Catalyst to make sure that that is an opportunity that can happen. And we must increase and sustain resource allocation. That's in SME growth. The I&I programs are very, very attractive internationally. And we must be able to have increased funding for new programs that would enable us, for example, as a centre, to drive the same type of approach in lung cancer, another disease that has a significant burden on our society. And for patients, the patients are really informed now about precision medicine. They will demand the best and they will accept nothing else. And Margaret Grayson and her team are very, very clued into this and tuned into this. And I'm delighted that we can go out and say of all the great work that Margaret is doing, not just across the UK, but also into Europe now in this domain. So the last piece is the economic shift. This is not just a healthcare issue. This is an economic issue. One, economic prosperity does not reside in commodities or sovereign wealth. The fastest growing economies in the world are those that are investing in technology and science. And you look to the Asian countries for your exemplars. Human capital is the single greatest contributor to economic prosperity. If you continue to drive biomedical research, you will increase the quality of high-care jobs, high-salaried jobs. You will improve the life expectancy of your community. You will increase productivity of Northern Ireland, and you will bring societal gain. And biomedical research is a catalyst for changing the Northern Ireland economy. So you can expand the market in precision medicine. You can increase your exports as a result of driving diagnostics and therapeutics development, and you will increase employment. So we have established that pipeline. It is working. It is changing patient outcomes. The infrastructure investment is absolutely essential, and there are critical inflection points now, which is investment with confidence in the long term because we can do this, and we have transformed or have the opportunity to transform an economy. 10 years ago, I wouldn't have expected there to be a biotech cluster around this building. There is now. And it's because we have the opportunity to expand this. I really believe we can become a leader in precision medicine. Thank you.
Thank you.
Thanks very much indeed. I'm going to just then continue and just to really follow quite nicely on what David had said in relation to this precision oncology report that we launched this morning. I'm just really going to touch some points in relation to it. Just if we just go and just in terms of obviously a big group of people involved in this, and I'm here representing them all and thanking them very kindly for their work in terms of doing this. Just to bring you back before we go forward, we have to look back as well and see that actually in 1995, before 1995, we had a very bad cancer service in Northern Ireland, very fragmented service, poorest outcomes for the majority of cancers in the United Kingdom, but we did something about it. Etta Campbell at the time, our chief medical officer, actually said we need to invest in the future and produced a plan, and this gets back to the comment Mark had earlier in relation to actually having a cancer strategy, because we had a cancer strategy then, and that cancer strategy led to, as we see here, if we take breast cancer as an example, 30% decrease in mortality by 2006. By 2013, we were the best. So it's very important that you have a cancer strategy that underpins how we actually move forward. And David has touched on the point here, but I just want to emphasise this is a team game. This is not an individual game. We work very closely with Liam, for example, there with the Cancer Registry, with Anna Gavin, because it's a team approach that actually gets us better benefit for the cancer patients and also can increase the Northern Ireland economy, as David has mentioned. And the other thing is you're part of that partnership. So we really want to work with you to drive this whole initiative forward. What I just want to do is just highlight just through the 4 exemplars that we looked at in our report, this health as wealth agenda, that we really feel that innovation and driving precision medicine is a very important part of improving the health of the Northern Ireland citizen, but also promoting wealth generation within the Northern Ireland economy. And these 4 examples go across the cancer continuum, and they really provide the evidence base. And it goes back to what Dermot said. Really having evidence and having data is very important to allow us to make decisions, and proper decisions that actually benefit all of us. And I couldn't emphasise that more. In precision radiotherapy, developing this new approach, so this approach which looks at stereotactic ablative radiotherapy, which is a way really of very accurately delivering high doses very precisely. In this context, in lung cancer, we now have over 100 patients. This is Jerry Hanna leading this programme, and it's transformed the management of early lung cancer in Northern Ireland. So this has been a game changer. This has been something that's gone all the way to the patient. It led to them receiving the Collaboration of the Year Award at the 2016 Quality in Cancer Awards in London. So national recognition for the ability to drive innovation into our healthcare system. Secondly, in relation to precision prevention, and we've had great support from Paula in this in relation to hosting an event in Stormont, again looking at the whole thing. We know cervical cancer is caused by human papillomavirus. We know a vaccination program works in girls, but what we now know is that we also need to think about HPV vaccination, because HPV vaccination doesn't only cause cervical cancer, it causes head and neck cancer, causes other cancers, it also causes STIs, and so we need to consider vaccination for boys too, and we call this jabs for the boys as a thing which I hope you like as the drive. So it's very important that we look at a universal policy. If we look across the world, many countries now are vaccinating boys as well, And we really have a chance to show leadership in this, to be the first in the UK to do that. And we've looked at it in terms of costings. You look here in terms of the costing, what it costs each year to treat head and neck cancer, anal cancer, genital warts, and you can see there the cost of vaccination is much less than that. So not only does it make health sense, it makes health economic sense. And so really, we really feel that we need to drive this. And what's important is recently, the figures are quite scary that's come out of the Republic of Ireland in terms of vaccination rates now for cervical cancer in girls in the Republic of Ireland are only at about 60%. So that's really worrying. So we really need to act in relation to this new universal HPV vaccination programme. Third, looking at precision treatment selection. So in the scenario where we're actually looking in early breast cancer, whether we give patients chemotherapy, which is more aggressive, or hormonal therapy, how do we select which patient actually gets which treatment? And the way in which you do it is through precision medicine. This test here, this is work that we've done with Janice Walsh in the Republic of Ireland. And what you can see here is just on the left-hand pie chart, you can see before the test was available, nearly 90% of patients were receiving chemotherapy, when actually only 30% of them should have been receiving chemotherapy. So 60% of them were receiving a therapy that actually was probably doing more harm than good. We want to bring exactly the same approach. And the other thing is when Janice looked at the actual costing in relation to it, again, you can see cost saving. So if somebody tells you this test is too expensive, they're not telling you the truth. Okay, because there's the example in the Republic of Ireland, nearly €800,000. In Northern Ireland, we've looked at it in terms of modelling it, €352,000 saving. Or sorry, £332,000 saving. So reduces unnecessary chemotherapy, improves the quality of life, is cost effective and also cost saving. And as David emphasised, I'm not going to dwell on this, but then this very important partnership, academia, industry intersect, is the way in which we can deliver. So precision medicine can deliver, but only if we work together and work in collaboration with industry, with the healthcare service, with patient advocacy groups. Just finally then, just to show you that we do all need to work together. So this is an example of one of our programs, and it needs to bring everybody together. So science as an ivory tower pursuit is gone. We need to work together, break down silos, work together, and that's what we do, and that's how we're effective. And finally, in relation to the recommendations of the report, new cancer strategy. We haven't had one since 2009, 2010. If you look at all the other nations of the UK, they all have modern cancer strategies. We don't. So we need that. Innovation needs to be part of that. We need to focus on precision oncology innovation and its adoption. So the data is there. I've shown you examples of the data. We now need to act on the data. We also need to look at the fact that we need to work together, so it's a partnership, and we would very much consider you as important parts of that partnership and want to work with you going forward. Data-driven approach, again, I couldn't agree more with Dermot. We work in slightly different areas, but we have the same challenges. I have exactly the same challenges as Dermot in my area in terms of actually the data is there, but getting to it, and this silo mentality of actually holding on to data is just not acceptable anymore. And in fact, the patients won't accept it either. So we really need to have this clear route for the evidence to then drive adoption. And so what we're suggesting is in terms of specific recommendations, SABRE, we've shown it works, so it needs to be extended to patients with metastatic disease. Universal HPV vaccination for both boys and girls in Northern Ireland. The 21 gene signature test, again, the evidence is there, both clinical and health economic. And the other two things that we feel is that, which data has been a big part of the conversation. So we need a way in which we can actually embed precision medicine by having a multi-stakeholder innovation forum. But within that, we need an evidence-focused outcomes research unit that takes the data, looks at it, and critically looks at it and says, yes, this does support, or in some situations it won't support. But we need that evidence base to actually drive forward. Everything I've said so far has been fairly positive, but I'm going to be negative at the end. So we don't want to go back to the 80s. And the situation, and Mark has raised it earlier, the access to innovative cancer medicines. It's a postcode lottery. If you live in Birmingham, you get them straight away. If you live in Belfast, you're waiting 2 or 3 years. We've had now 4 health ministers, each of whom have promised things on this. None of them have delivered.
And still, the Northern Ireland cancer patient waits. So I'm essentially saying, can we work together to make sure it doesn't go to a fifth Minister of Health before we actually get something that cancer patients deserve and need? And certainly, I can provide you with data in relation to that, in relation to the differences between what's happening here and what's happening on mainland UK. Thank you very much.
Okay. We are really, really tight in time here, so I'm going to suggest we leave all our questions for our walk around if members are in agreement to that. Can I, on a personal level, thank the centre. I know, and you know, in the last mandate, you were so approachable. And when it comes to the working together element, I would encourage everyone to work together. You gave me invaluable information, especially when it came to HPV, which is something that I will continue to champion. I think you know that anyway. I am rather disappointed that we still haven't progressed with the breast cancer issue, but I think it's something that, again, we're going to continue to champion with that. So on a personal level, Mark, thank you, and David, thank you. I totally agree that we needn't see that there's any barriers there, that scientists are way above, and we shouldn't be speaking to them, because I've found it the complete opposite. I've been in this building many times, and also the colorectal cancer as well. I attended an event here, and I'd encourage members, if you get invited to anything that is going on in this building where it's hearing evidence and hearing experience, please attend. I've learned so much through this centre on many issues in my last mandate. So I'm just going to say, and I'm going to stop there, I'm going to say thank you. What we're going to do then is we'll ask questions as we do our walkabout with you, if you are happy enough with that and members are happy with that. Is that okay? Because we are tight in time. So thank you very much, and we'll move on with our agenda, and we'll see you very shortly for our walkabout. So thank you.
Thank you.
Okay, members, if we're all in agreement then, can we get back to our agenda, if I can find where I'm supposed to be on the agenda? Yep, okay. We're going to, can I just actually advise members there's a press release should be sitting on your table. You may have had a chance to have a look at it. You'll certainly have had a chance to have a look at it before we leave today. So can I just ask members if they have had a chance, are they content with the press release? I think it's important, given what we have heard today that takes place in this building, that we shout it from the rooftops. I do it in any opportunity I can when I'm speaking about research and how well we're doing things in Northern Ireland. So are members content that we put out a press release? Yeah. Mark, is there something you want to bring up?
I think the scientists we met, have been great. But committee meets top scientists at Queen's University. There are other scientists at Queen's University, so hang on. I'm top, so meets, I don't know, eminent scientists at Queen's University.
All right. Okay, that's fine. All right, members.
I was just wondering, I have a few questions. Well, if we're doing them in a walkabout, they'll not be recorded then, or could we ask maybe the clerk to take a note of them? They'll not be recorded in this.
No, they'll not be. It's just because we've been tight on time, and I know there's a lot of members want to ask questions, so I've asked if they can just do that while we walk around. Now we can, I suppose, take a note. You can take a note.
The other thing we could do is compile those by way of a letter, and then we'll get a written response, which would be on the record and will be available for members.
Yeah, it's just I was really looking forward to questioning there, and I've sort of been busy scribbling away. But if we could, then how will that work then in practice then? If it's not on the record, but
you could propose that the committee write.
So you
could give us your question.
Oh yes, okay. Can I do that then? Yeah.
Okay. As I say, I have found these guys really, really approachable. So any questions anybody has, you can come directly to them anyway. They are very good. Okay, if I can move on then to item number 8, which is an SR 2016/384, the Health and Personal Social Services Superannuation Health and Social Care Pension Scheme Amended Regulations Northern Ireland 2016. Can I refer members to page 28 to 34 of your meeting pack? The committee considered and approved the SL1 policy document for this rule at its meeting on the 20th of October 2016. There have been no changes to the policy content since the SL1 was submitted to the committee. Since the pack was circulated, the Examiner for Statutory Rules advised that there is a drafting error, but that the department intends to rectify it by amendment. Are members content with the statutory rule subject to the department's commitment in correcting this error? I know that was rather wordy there, so I just about got it out, so everyone okay with that? Thank you. Okay, so can I now formally put it that the Committee for Health has considered SR 2016/384, the Health and Personal Social Services Superannuation, Health and Social Care Pension Schemes Amendment Regulations, Northern Ireland 2016, and has no objection to the rule. Great, thank you, members. Item number 9, correspondence. Can I advise members there are 19 items of correspondence at pages 39 to 688 of the meeting pack and 2 in the table papers. Can I just draw members' attention to a few issues? Item 9.8 at pages 339 to 340 is a response from the South Eastern Health and Social Care Trust regarding the Prisoner Ombudsman's report on the serious self-harm incident at Maghaberry Prison. Also at 9.20 at pages 686 to 688 is correspondence from the Committee for Justice informing this committee that the Chief Executive of the South Eastern Trust is to give evidence to the Committee for Justice on this matter today at 2 p.m, which I, along with the committee clerk, hope to attend to sit in just in the public gallery. And also related to these items are 9.21 and 9.22 at pages 3 to 53 of your table pack, which is further correspondence from the Committee of Justice regarding recent investigation reports by the Prisoner Ombudsman into the deaths in custody of Mr Jeffrey Ellison and another prisoner, and Mr I. Excuse me, members. Are members content to note that all of these items and return to them at next week's meeting when we will be briefed on the matter by both the Prisoner Ombudsman and the Chief Executive of the South Eastern Trust, Jerry?
Just not sure. We're being briefed next week, is it?
Yeah, we are indeed.
Thanks.
Okay, so I think we're going to put a lot of that will go into your pack again next week, just that you'll have it's within the pack. Yeah, it has. Absolutely. So I think that's one of the reasons why the committee clerk and I feel that we want to sit in today on the Justice Committee. Okay, members, can members agree to that then? Yeah. Thank you. Items 9.10 at pages 533 to 534 is correspondence from the Children's Heartbeat Trust regarding the All-Ireland Paediatric Cardiac Network. And then items 9.17 at pages 597 to 663 is correspondence from the Committee for Agriculture, Environment and Rural Affairs regarding a report by Rural Support Health and Social Effects of the Agricultural Downturn in Northern Ireland. Are members content to note these items for now and return to both of these issues at our January strategic planning sessions? Agreed? Thank you. At items 9.12 at pages 537 is an invitation to myself to speak at a Macmillan Cancer Support event on the 6th of December 2016. I'm happy to do this. Are members content that I go ahead with that? Thank you. Item 9.13 at pages 538 is an invitation again to myself to attend the Chief Officer's Third Sector Leadership Awards dinner on the 24th of February 2017. Again, members, I'm happy to attend. Are members content? Thank you. Are members otherwise content with the proposed actions as listed on the correspondence cover sheet at pages 37 and 38? Agreed, members? Thank you. Item number 10, can I refer members to pages 690 to 691 of your meeting pack in the Forward Work Programme? Are members content to note the Forward Work Programme? Thank you. Any other business? Do members have any other business they wish to bring up?
One very quick thing, and maybe the clerk might be able to help me. There's one thing missing from the correspondence tracker. Just maybe in the pack, I haven't picked it up. It's with regard to the heart screening question for young people.
Okay.
I don't know, maybe I can't find it. It didn't seem to maybe respond to it.
Okay, leave that with us and we'll check that out and we'll get back to you, Robbie, if that's okay.
Yep, sure.
All right, thank you for bringing that up. Okay, item number 12, members, is date and time of next meeting. Next meeting will take place at 10:30 a.m. on Thursday the 24th in the Senate Chamber, Parliament Buildings, where we were briefed by the Prisoner Ombudsman and the Chief Executive of the South Eastern Health and Social Care Trust. Can I encourage members to definitely try to attend our pre-brief at 10 a.m. ahead of this session, where I think we might be able to discuss some issues and get some further information from the clerk. Okay, members, thank you.